Do you not love that?
Like, I think it depends on the kind of cracking up you're looking for. Like, are you looking for like
organic,
like a screech or like a
you're like
like a whale?
Your body laugh. That's like.
You did that pretty good. Fuck.
Welcome to the Second Round podcast, where I get together with some of the best people I know, professionally and otherwise, to commiserate about our experiences in the workforce and say all the things HR would probably be on our asses for if they knew we were listening to this. So, as my first guest, I have Julian Colina, physical therapy student from University of Miami, but I'll let you introduce yourself. Tell us who you are, what you do, what you're drinking, anything else we should know about you.
Well, my name is Julian. I am currently doing my doctorate of physical therapy at the University of Miami, and before that, I was an exercise physiologist. I did pharmaceutical branding sales, but, you know, we don't talk about that too much.
Until another episode.
Yeah, that's a whole other episode. And I'm drinking Moscow Mule, my favorite.
And that's, your go-to drink and what we're both going to be drinking for tonight.
Yeah, I mean, the ginger just makes me feel like my body's a temple. I love that.
Definitely feels healthy.
Right. Ginger.
Healthier than a vodka cranberry, of course, which is my go-to.
Right.
So I wanted to have you on today because we wanted to talk about breaking into a female-dominated field, which is pelvic health, and you've chosen to specialize in pelvic health. So for those who don't know, if you could just start with, what is pelvic health? How does it relate to PT?
So pelvic health physical therapy is essentially, when you think about it, pelvic health involves muscles just like any of the other movement systems a physical therapist would treat. And it's for all types of dysfunctions, but anything ranging from stress incontinence, which essentially is leaking when you're laughing or trying to pick something up, etc., to things like erectile dysfunction, painful penetration, all kinds of dysfunctions in that kind of realm.
So you mentioned ED.
Yes. So
pelvic health exists for men and women.
Yes, it does.
Okay. But you've chosen to specialize in helping women.
Originally, that was my plan, because I was really fascinated with the pregnancy cycle and all the changes that a woman's body goes through. So I was really fascinated by that, but I have started taking some continuing education, which I know we'll talk about later, in male dysfunction, and I think they both have such interesting nuances to both sides. And I think as a male, since we are talking about kind of breaking a gender barrier, I do think it'll be a little bit easier for me, also as someone that identifies as male, to be treating those types of patients.
So in the pelvic health space for females, you have found, and correct me if I'm wrong, you have found that female patients prefer a female provider. And do you find that that's the same with males in the pelvic health space? Do they prefer a male provider? Do they care?
I think it depends. I mean, I think definitely, at least from, my intake, I have seen more females or people with vulvas, as we say in this field, prefer to have a practitioner that identifies as the same. With men, I think it's a little bit more varied. I have heard that there are some groups of men, kind of like Orthodox religious type of men, that will only see other male practitioners or practitioners that have penises. But I do feel like that is the kind of trend that I see, that people kind of prefer to have someone that they can identify with.
So you're in the clinical phase of what you're doing for PT at University of Miami, and you've tried to get to your own clinic and volunteer or do whatever clinical hours there. And you texted me earlier this week about an experience that you had that you were like rejected for a pelvic health situation simply because you were a male. Tell me about that. And tell me about, similar experiences with that.
So with the experience that I texted you with, essentially what happened was I applied for this specific clinic, was waiting and waiting. Other of my cohort members have heard back from their interview sites and I'm still waiting. And then I finally hear that they weren't able to offer me a spot. No interview ever happened, by the way. This was just...
And you've been continuing your education. You've been furthering yourself.
Far more.
And you're as qualified as any woman would be.
Yeah, especially compared to a student, I would go so far as to say. And the instructor said that they felt their patients would not be comfortable with having me around. So I didn't even get an interview, not even sure if the resume was even looked at. If it really was just my name, they were like, oh, penis, bye. Frankly. But that's the barrier that we face kind of entering this subspecialty in the workforce.
And do you think because it's a specialized thing, are they allowed to say that to you? Is there a lawsuit there?
I mean, it's tricky because really, the clinics don't even have to offer student spots at all.
Okay.
So really there's a kind of leeway there because the clinic is already kind of, I don't want to say going out on a limb by offering a spot, but basically, they don't even have to be doing that. So they do have
They're already like, okay, we don't even need to have you here, but you're also male. So,
right. Exactly. Exactly. But that's the barrier. And even when I took my first continuing education, which certified me to do like intravaginal exams and things like that, I walked into the class. This was in Philadelphia. So I'm traveling for this education. At Temple University, I walk into the classroom. I'm the only person with a penis in there. And the second I walk in, everyone just stops and gives me like this kind of like stare. And you can just tell that it's not expected that a male or someone with a penis would be there. It's still kind of a blossoming field, and I think it's just still not expected at all.
That is literally how I felt walking into a Calc 2 class on an engineering campus at FIU. I was one of very few women, and again, it was like this thing of like, it's not expected. What are you doing here? And people are watching you very closely. Very closely. Now let's talk about this and tell me if this has impacted your experience. You are openly gay. Mm-hmm. So you're part of the LGBTQ community.
Right.
Do you think that helps you, hurts you in the field where you would be treating women? Like, do you think that makes a difference?
I wish it didn't for other people in the LGBT community and other males, but I unfortunately feel like it could make a difference. I do feel like there will be some women that would be more comfortable if they felt like they weren't being treated by a like straight cis penis owner.
Someone could potentially be attracted to them in such a sensitive sexual setting.
Right. And I have asked around about it, and I feel like I have kind of gotten that input that there is a little bit more of a comfort level. But then I also have the flip side where if I'm working with people that have penises, then it's like, are they going to be turned off by me because now they have a practitioner that could potentially be attracted to them? So
it's a catch-22. And so that brings me to my next question. What do you think would need to change? Like, for you to see on both sides, for more men to be in the women's pelvic health space and more women to be in the men's pelvic health space. Like, what do you think what would you change? How are you going about trying to change that in other practices?
Well, I think a couple things should change. I think from the educational perspective, I think it should be encouraged that it's not a field that only women can do or people that have vulvas can do. I know, like, when we started kind of first learning about anything in this realm, you can kind of tell that sometimes the guys in the class get like a little, they're just not as maybe comfortable talking about it. And I think with gynecology in general, I think people kind of just associate it with a woman's type of profession. So I think in the educational side, you can already kind of start pushing that, you know, men have problems too, erectile dysfunction, premature ejaculation, prostatitis, all kinds of pelvic pain. You know, men can have these conditions and they might want to be treated by other men, maybe someone that they feel will understand their complaints. So I think from the education side, that could be starting to get pushed forward. I think in the clinical realm, I also feel like the doctors, like the MDs that people with vulvas are seeing, I think there has to be a change from their perspective also. Because I think it's still such a new field that there are some doctors that don't even know about it still. Actual MDs that don't know about this field or what it does. And if they do know about it, it's probably still kind of an older mindset where it's more geared towards quote unquote women's health instead of pelvic health. And recently, someone told me that they were having vulvar pain and they went to their female gynecologist about it, who's an older woman. And the doctor told them, oh, don't worry about it. That's a problem that all kinds of women have. And
it's this thing that just because it's common doesn't make it normal.
Yeah. And then she was like, just use lube. And the person was like, oh, but I have genuine pain. And
outside of a sexual context.
And the doctor was like, lots of women your age have that. And it stops there. And that could have been a spot where they talked about maybe referring to a pelvic health physical therapist and seeing if there's a muscular issue or something going on that we can help with, but it was never even discussed. Not at all.
So let me tell you this. So you obviously know that I just had a baby 3 months ago.
Right. Congratulations.
Thank you. But I had this horrifying experience, and I haven't told anybody about it yet. I'm going to tell you.
I'm excited.
I woke up, and so obviously with like Reels and Instagram and all that stuff, there's a lot of people that are women that are PT, you know, therapists, and they always make that funny video where like you sneeze and you cross your legs and people think it's funny, but it's again one of those things. It's common, but it's not normal.
Right.
And I would always laugh and be like, oh my God, that's like so not going to be me. And you shed light on that's like a pelvic health issue. It's because you don't have strong muscles down there. So I woke up the other day and like I had to pee. So I'm like running to the bathroom and I did not make it. And I had no control to stop peeing. Like I peed all over my legs, like right before I got to the bathroom. Mm-hmm. And this is not even something that's talked about because you have to go to your OB after like the 6 weeks or whatever. Right. And there's no like, hey, let's check for diastasis recti, if that's how you pronounce it, right? Mm-hmm. Diastasis recti. Let's check. He didn't ask me like, how am I peeing? Like how like basic bodily functions that you literally take advantage of until like you have a baby and you didn't know it was going to leave you. Mm-hmm. So what is going on right now in terms of like what you're learning in school and what you're seeing in the clinics? Like, is working with an OB even an option? Like for pelvic health therapists? For pelvic health, yeah. Like how do you even?
Yeah,
like, what's the roadmap for this?
I know
at this time
of a pelvic health therapist who I can't remember the exact type of deal that she made, but she had some kind of situation with the OBGYN where he would refer patients to her like for a pre-surgical consultation where she could kind of give the patient like a pelvic health physical therapy examination, kind of educate them on some things that might happen from the surgery, that might not happen, some things that they can kind of plan for, and to, you know, with the goal of improving outcomes after the surgery. So there definitely is a roadmap that pelvic health therapists can communicate with their OBGYNs, with urologists, like proctologists, like with all these medical doctors, and try and kind of close the gap between these professions, because really they should be working closely together instead of operating like on two different planets, you know?
Right.
I mean, there should be a relationship.
So right now in your class, are you the only male interested in public health specifically? Yep. In a class of how many?
I'm in a class of like 62 or 63. I forget.
That's a lot. And so obviously you've also been networking on LinkedIn. You've made some connections
Yes.
with male,
Yeah.
also gay,
Yeah.
pelvic health PTs.
Yes.
What's that been like, and how did you even find them? Is there a network? Like,
I frankly don't remember. Well, so on LinkedIn, I definitely just kind of searched for pelvic therapists. And actually the one that I found on LinkedIn just happened to be gay. I didn't even know that. Yeah.
Right.
But I found with the networking that, at least in the pelvic health community, everyone just seems so supportive, and they're always willing to help. And I found that when you just kind of approach them very earnestly, just kind of asking for their feedback, for their advice, or even just to kind of bounce things off of them, they're very receptive to it. And it really opens a lot of doors and a lot of connections.
So you've not experienced really like any gatekeeping of women's health or anything like that?
I feel like I've noticed a lot of gate opening.
Okay, good.
Yeah. The one that I found via Instagram has also been a really great tool for me in terms of networking. I actually was in contact with this pelvic health therapist, woman, and I talked to her because I was taking, it was her classes on erectile dysfunction that I'd taken. I took a class from her on erectile dysfunction, premature ejaculation, and chronic pelvic pain in men. So a lot of male-focused things from her. So I asked her if she knew of any male therapists that I could reach out to. She gave me 2. And I reached out to both of them also via Instagram. And they've both been incredibly receptive and open to talking to me and offer advice. And it's been fantastic.
That's good that you have some mentors. So there was one person who, I don't know if it's one of those 2, but that reached out to you and was like, hey, come do your clinicals at my clinic. And
right.
He was a male, PT, pelvic health, and gay, literally you, like
right.
10, 15 years into the future.
And blonde.
Okay, so the fairer type.
Right.
But what happened there?
So what happened there was, I, of course, on my end was ecstatic.
It sounds like a dream.
Right. The issue is that with the education system and clinics, there needs to be a contract settled to allow a student to do a clinical there. And not only do you need a contract like with the clinic, but it also has to be certified that you will be able to, have like a certain amount of patient hours and hands-on time and those kinds of things. So those kinds of legal boundaries and like framework needs to be established. And unfortunately, what was told to me was that it would take too long to establish that all of that by the time that I needed to select a site for the clinical. So I would have to select the clinical that I would have gone to him by actually like this upcoming Friday. Yeah. So no contract could be drafted and completed with all of the certification by that time frame, unfortunately.
Yeah, that seems incredibly difficult.
Yeah.
And not very encouraging to find like your own outlets, because it's not like, I don't even know how you would know, but like University of Miami, has their own set contracts, they are what they are, but
right.
It doesn't seem like there's much of an opportunity for you to like go out of your own way, find your own people, maybe find some of your own people that you identify more with, and it's much more specific to what you want to do.
Right. From the student side, it definitely seems like no. But the good thing about networking is that they'll be there if you build that rapport, and if you show the interest. So I am planning to still learn under him, just under my own private time, not under the time of, under the time or eye of the University of Miami. And that's still something that I wouldn't have had if I didn't reach out to that first female therapist and then asked her for referrals to these male therapists and then reach out to them. So it's still a fantastic opportunity that wouldn't have been around if I didn't, put myself out there and kind of try to open those doors.
And do you think if you hadn't, experienced the initial resistance and, prejudice, so to speak, with going into like a female, quote unquote, female dominated, field, because it's also female patient dominated or exclusive, would you have changed and maybe gone the, some would say, the easier route and just like kind of dabbled in male health as well? Do you think you would have just done female? I mean, it's still so early. You could...
If I didn't have like the roadblocks, you're saying?
Yeah.
Or it's hard to say. I think my personality is definitely, I can be quite combative. So I think when I started getting roadblocks, I actually got more invested in trying to tear them down. But I feel like it's important to advocate. I feel like the field is not called women's health anymore. It's pelvic health. And if it's not me that is tearing down the barrier or starting to tear down the barrier, it's going to be the student after me or the one after them.
Right.
There's actually already a student who just started who is a male and also a penis owner, I should say, and wants to do pelvic health. So there's, the field is changing. It's slowly changing. But I think that these barriers will be taken down. So I feel like even if I didn't have as many roadblocks as I am getting with kind of like that gender barrier, I still feel like I would have advocated for clinicians like myself.
Yeah,
right.
You would have moved the needle either as big or as little as you could have in the time that you're given.
Yeah.
Which is good. So, we've gotten to know a little bit of like what you do, what you're interested in. And then our second segment is kind of, going to Reddit, which is, a place for trolls mostly. And I wanted to get like some of your opinions on the same kind of scenarios, with the male provider, female patient kind of thing.
Another sip of this drink.
Yeah. Go ahead. And it's,
I'm ready.
So I just want to like read some of these questions to you. I also have a few responses that I would love to get your opinion on.
Okay.
But first, let's talk about, it talks to the male gynos, but we'll just say male providers, and especially for someone who's interested in public health, what initially got you interested in pursuing a career dealing with vaginas, and what's the best thing about the job?
So for me personally,
yeah,
what got me interested was very early on, we had a lecture on the different specialties of physical therapy. And this one in particular, I just think the quality of life impairments really struck me. I mean...
Not being able to control pee is...
significant.
A privilege.
Yeah. There's definitely those that... I also feel like the problems they're very like nagging and they're constant.
Yeah.
I mean...
chronic, yeah.
Yeah. And it's just things that you always worry about. So like with the leaking and like urination and that kind of stuff, there's that, but also from the sexual standpoint, so like the pain with penetration and like erectile dysfunction, I felt like in my personal life, I've always been someone that's very open book about that entire field. And I feel like somehow I've gotten other people to be very open about those things with me, even if I just met them at that moment.
I think your openness also like invites
more openness.
Yeah.
So I just feel like, and those conditions specifically, I feel like they really impact people. They impact your self-esteem, your relationships, your willingness, your ability to just kind of feel like yourself. And I feel like those really kind of touch me. So that got me into it. And then the more I researched it, the more the passion just kind of grew for those types of patients.
Yeah, so a lot of people said something similar to that, or like they took a class and then they got really into it. So we have this one post who he completely ignored the question. So I'm going to read that to you, and I want to know what you would say to this person. So I have always had a problem with male
Okay, got it, right.
with male gynecologists examining women. When I was a young man and found out what a gyno was, so he didn't even know what a gyno was, I was devastated to learn that my then girlfriend was going to one.
Devastated. Crushed.
It bothered me pretty bad. Now I am married, and I went through similar with my wife, who has agreed with me that it was wrong to see a male for to see a male for these exams. I find it appalling that a man would enter this line of work, and furthermore, I think it leads to immoral behavior, such as promiscuity, by opening the gates of immodesty in young women. I really don't see how anyone can find this practice acceptable. That is why we have male/female restrooms, and I think it should carry over into the medical field. This causes a lot of emotional trauma to men and women. How can you do it knowing this?
Well, let me explain to you how I can cause emotional trauma. So I think, honestly, it sounds like there's a little bit of kind of like he's
not stable in his masculinity, obviously.
There's that. And I also kind of feel like he's almost mirroring maybe like a little bit of what's inside himself onto others, because
he's
it's like
projecting, like, does he feel like he has promiscuous thoughts when he sees a female provider?
Exactly.
Like,
that's what came into my mind when you said that. Like, why do you assume that this provider is going to have a promiscuous thought? Do you have promiscuous thoughts when you see women? Like,
so you have told me that you have like practiced on your fellow classmates, like
right.
You have done public exams, you've done, the whole nine. I mean, you are gay, but also like just in general, you've done male public exams as well. Like, you're a doctor and you see like 90 million of these a day. Like, I can't imagine you can't look at this from a clinical, objective perspective. Like,
yeah, no, it could definitely be clinical, it could be objective. And these people are, I mean, of course things happen, but they vow to like take care of you, and believe it or not, like, just because your provider's a male and you might be a female, like, they're not immediately attracted to you, believe it or not. And the same, like, vice versa. So that post it seems just a little bit ignorant, I think. And I feel like there are some people that think that, like a penis owning practitioner wouldn't be able to treat a vulva owning one because they don't have the same parts and there's not going to be like an understanding.
Yeah,
and I can tell you, I definitely will never know what it's like to have a vulva, to be pregnant, to give birth. I won't know any of those experiences myself, but I can tell you the science behind them. I can tell you what is normal and what's not normal, what science says should be happening. I can, give you best practices. I can give you all of those things anyways without knowing those things. And I think it's the same kind of principle. Like, your cardiologist could give you great care and have never had a heart attack themselves. Your orthopedist could have never broken any bone and still done a phenomenal job repairing your broken bone. I think it's the same kind of principle. I think it's just because they involve like taboo subjects, people are very like spicy about it. But I think it's the same kind of principle with any medical professional. Like, they're not going to have the same thing that you have, maybe, but they can still give you,
adequate care.
The adequate care that their who knows how many years of education gave them. I mean, that guy's a mess.
He definitely sounds like he needs therapy, and I'm also afraid for his wife.
Yeah. I mean, it sounds like he forced her to say that she had...
What really gets me is, like, that she admitted that it was wrong to see a male. Like what? You're going to a doctor, like, to seek care. I don't understand. Like,
yeah. I don't even want to know. I wish I could honestly be a fly on the wall for that home conversation that they had that day. So I could have just seen how it all went down. Because, wow.
Yeah, that is really funny. So you mentioned something earlier, treating with someone with the same parts as you versus not treating someone with the same parts as you. And what you bring to the table is impeccable knowledge and always furthering your education. And what other tips do you have for someone who is going into like the opposite gendered patient-dominated field? Like, is education enough? Like, what is there anything more that they can do? Like,
so unfortunately I learned that education is not enough because of the recent experience I had getting rejected. But I will say one thing. I mean, of course education does play a role. The more tools you have in your tool belt and the more education you have, the stronger you'll be. And that's just general. But I also think what's probably more important, especially in this field, and at least what's been more important for me, I think, is the networking. I think that really opens doors. It brings a lot of awareness, the advocacy. It just, I think it kind of just opens people's eyes and makes people more willing to help you. And I think that's huge, especially in a field where, doctors don't know what we do. They don't know who we are.
There's no visibility.
They see your penis and they're like, bye. Like, you're not, go do sports. I think the advocacy and the networking, especially between, like, amongst ourselves, is huge. But I also feel like, at least if you are male presenting and have a penis going into this, a field like this, I think it's important to be very aware that what you're doing is like, is personal. And that you have to tread the waters very carefully. Because, that guy, even though we just roasted him, his fears may have like a very real, stem, that may have come from somewhere. Maybe it was his mom or his sister, who knows, and actually at that class that I went to in Philadelphia, this blew my mind. I was practicing on my friend, and I just finished doing like an internal exam, and I said, okay, I'm going to withdraw my finger now. So whatever, we're moving on to like the next thing. And an instructor comes up to me and she says, hey, I heard, I was kind of like listening in on your evaluation. You really want to be careful, especially like as a penis owning therapist, of using the word withdraw, because it might trigger some women that might have had, some kind of trauma. And, I was feeling like pretty confident at this class. I was feeling good.
I would have thought like, okay, you've narrated the action, which a lot of people already don't do. To me, I'm like, that
withdraw it.
Actually, good. Right. Thanks for letting me know. Approved. Like,
it shocked my mind, because I think that was one of the first times that I realized, like, wow, like I have a whole other set of barrier and a whole other, like web of things I have to consider, that besides just, do I know the material and can I execute it? I have a whole thing that I have to kind of be aware of.
Emotional, aspect. So do you guys have any training on that? Like, is that a part of your like basic training? Like, if you choose to go in, even if you choose to go into that niche, specialization?
With me, they told me this because I was the only male there, and I think
they're like, hey, okay, it's easy to point out one,
right,
but it's such a one-off.
Right. So I'm not sure. There are sub-special courses that you can take specifically on treating like, sexual trauma survivors. But I'm not sure like if, there's one specifically for like a penis owning pelvic health therapist treating, the other part.
Right.
But yeah, when she said that, my mind was blown. And one of the things that it's what you said about narrating, that's one of the tips also. Narrating, make sure that you say everything so that they know that they are in control, they know exactly what's happening all the time. But also, being very aware of the verbiage of withdraw, spread, like all these kinds of like words that might like trigger some kind of memory.
Yeah, because everybody has associations to it. So like immediately I'm like, you said spread, and I'm like, oh, okay. Like, a million things come to my mind. Yeah,
because that's another one, like people like to usually like to insert your finger, vaginally, you'll like spread the labia. But it's like, if you're going to say like, okay, I'm going to spread the labia now, then some people might be like, you're gonna what? And of course, like, you don't want to use the words like, like lips or something.
Oh God.
we actually heard that in class.
Like from a professor? Like,
yeah, they were like, you want to be proper, don't use that.
Yeah. They said that.
No. No, they said don't use that.
Yeah, no colloquial terms in a medical setting.
Right. No cooch.
Okay. So, okay, that was good. So then I also created like a game for you. So
okay, great.
It's basically we're gonna play Unpopular. I made a medical version for you. So Unpopular Medical Opinions, and these are just quick fire. I mean, we'll see.
Ooh, what comes I'm nervous.
It takes several gulps of drink. And we're just gonna, and so this is just like an amalgamation of like,
right, good word.
Searching, thank you, searching the internet, and trying to find like the funniest, like weirdest, or like eyebrow raising.
All right, my heart's racing. Let's go.
Okay. So number one.
Wait, what do I answer? What do I have to say?
You just agree, disagree. You know, like.
Okay, I'm sweating. Let's go.
Okay. Chiropractors are quacks. All of them.
False.
The entire
Shit.
We're so half strong.
Okay, who wrote that? Do you have the username? What's the username?
We need to reach out to them immediately. Why are people? You know, maybe because you can find them in a mall. Like the legitimacy
at Westland Mall. I think. Ooh. It's funny because there is, I think, like a little bit of I don't want to say like a feud, but I feel like physical therapists and chiropractors can kind of treat some of the same things. Some of them, there's a little bit of overlap. But there's definitely, you know, they are doctors of chiropractic. I mean, it's not like they got like a certificate and it's like, okay, I'm a chiropractor now, I'm going to open a practice. You know, it's like they have a whole education. And I think that people may not be aware that they're like doctors of chiropractic.
So it's a separate school. That's not like a subspecialty or something.
Yeah, it's a whole other thing.
And it's legitimate.
Yeah, and I mean, I feel like with all like professions, you're going to have a quack here and there. You know, you're going to have someone that's just wild.
It's the people, not the field.
It's some of the people. I mean, maybe that person went to someone that just completely like rearranged their entire skeleton, but but you know, it's the people, not the field.
Okay, so
leave the field alone, those poor people.
They're legitimate. Okay, so the next one, fibromyalgia isn't real. And I have the original post for this one. So, fibromyalgia isn't real. It always seems to be somebody with a history of anxiety and depression and an enabling family member.
Not the enabling family member.
When I see them in the emergency department, it only seems to get better with an IV, and then they list some drug. And then so a few people did say this, and it was like, fibromyalgia isn't real. If you have fibromyalgia and chronic Lyme, with an allergy list a mile long, I'm pretty much done with you.
Shit. I'm pretty much. I could see how it would be tempting to think that. But I would say fibromyalgia is real. And I think it's funny, like they mentioned the anxiety, depression. You know, I think those things can lead to like central sensitization.
Yes.
Leading to like this increased sensitivity to pain. And I feel like pain is way more complex than people think it is. Like,
so we have a friend that she hates when she goes to the emergency room or she goes to the doctor and they ask her to describe, you know, pain on a scale from 1 to 10 because she's like, it's so subjective. Like my 7 could be your 4. You know? Like, what does this mean? Like,
yeah, and that kind of goes into it. Like, you know, what's like your views on pain? Like, are you catastrophizing it? Like, what is pain for you? I think people that aren't really into a medical field just kind of assume like, you know, pain is like when you pinch yourself and like, oh, it hurts and that's pain and that's it. But there's a lot of factors that go into it. And it's very, very complex and people are still studying the science of pain and how it changes and what exactly it is. And, you know. Yeah.
So have you heard, and I am not a doctor, so, but basically like our brains control, you know, pain. Mm-hmm. And so I've read that when you see something happen to your body, like someone punching you or someone stabbing you, it hurts more because you can see it. And there's kind of like an argument that like, if you can't see it happening to you, like it hurts less. Like, have you heard that at all? Like,
I haven't.
Just drives me wild.
I personally haven't heard that. I think it is interesting because I don't know, I'm sure this has happened to you because I feel like this kind of stuff happens to you, but I feel like, have you ever like, you know, like you're going about your day and then you look down and you see there's just like blood dripping down your leg because you got like a random cut from like somewhere that it just happened.
Yeah.
it's funny because I feel like, you don't know that those things happen. And just after a while, you're like, oh, I actually feel like this weird little pulse in my leg. And then you're just like dripping blood.
That
and it's like, oh.
literally happens like with women and their periods all the time. Like you'll
Right.
be feeling like kind of weird and you're like, whatever, I'm just not feeling weird. And I'm not feeling good. And then you'll see that you got your period and then you'll all of a sudden like the cramps,
And then it hits, yeah.
like the lethargy, like it's just everywhere.
Yeah, so I feel like I've never heard of
But there are some instances where like...
and I'm also not the best at pain science, sorry. But, I can't spit out the facts on that one.
Yeah.
But that is interesting if that is like a thing about like if you see it, if it hurts more.
I mean, like, yeah, of course, if someone comes and punches you in the back, you are going to feel it. But, to what degree? To like what up?
Right.
All right, so fibromyalgia is real. You heard it here. This one I think you're going to...
That was a funny post.
This one I think you're going to find interesting. Physical exams are mostly pointless. Annual physicals for people under the age of 40. Ridiculous.
Absurd. So this is actually funny. I really feel like it depends on the practitioner that you go to.
Okay.
Because...
So there are some quacks doing some annual.
There's some quacks. But, so this is funny. I've had some physicals where it's really literally quite like, it's just like, they'll take a blood pressure, my heart rate, and
vitals,
like...
yeah.
My vitals, they'll feel my lymph nodes and they're like, okay, bye. And then I recently did a physical kind of expecting the same thing. And this was actually at, it was a nurse practitioner at a Walgreens Minute Clinic. And she threw everything at me. I was like, damn, girl, you still going?
Not that many people walk through there. So she's like, gotta get all the bases.
She hit me with everything. So she did the vitals. She did an eye test. She looked at she looked at the eyes. She looked at the ears, the throat. She tested my cerebellum. I'm like, girl, you see me walking in here?
I haven't heard that since intro to psychology.
Cerebellum?
Yeah. That's not the thing.
Yeah. She did, it's essentially a test. Well, the term is dysdiadochokinesia, but it's where they make you do what were the ones that she made me do?
What?
She did where I had to, for the people listening, if you're sitting down and your hands are, your elbows are bent,
okay,
and your palms are facing your thigh, literally just flipping your palms up and then back down quickly.
And what does this do? What does this tell us?
If there's a cerebellar problem, it's not going to be as rapid.
Okay.
And there was also for coordination, she had me if my arm is out at my side, to touch my nose with my fingertip and then back out, and again fast. And she looking for am I missing? Am I yeah. spastic, or am I slowing down? I was I have never seen a nurse practitioner do this.
No, I was going to say, I can confirm I've never had a physical that includes that.
Right?
So she was
even
just
a vision test, I'm like, wow.
These muscles.
I was there for a while. I mean,
clinic, my ass.
I left feeling fantastic. I was like, wow. I've never felt more confident in my health.
The pinnacle of health walking out of that Walgreens.
Yeah. She was fantastic. I wish I remembered her name. But she was great.
So, depends. Physical exams.
No, okay. they have a place though. I mean, they're not. They're not. Things can definitely happen to you below the age of 40. To that person. Going back to randomly, suddenly feeling pain and looking down and having blood coming out of your leg.
So we've got someone a little bit self-important, I think, in this next one.
Okay, I can't wait.
The doctor title should only be used for MDs and DOs. White coats and the term doctor, when used in the traditional medical sense, should be reserved to physicians and surgeons only. Crazy that I see more nurses, dietitians, phlebotomists, etc. wearing coats than the doctors. Also boggles my mind that while PA and NP, so physician's assistant and nurse practitioner are grouped together as mid-levels, nurse practitioners can see patients independently, just as you were saying. Nursing curriculum, is not anywhere near what it is for the PAs. I'd take a PA over an NP any day. Does it matter?
Is this all that same person?
Yeah.
Are they just popping off about...
Yeah, just...
All of
they
it.
want to see the segregation. They want to see the medical case system.
They want the hierarchy.
Yeah, tell me you're an MD without telling me you're an MD.
Right. Tell me you're a bitter MD student. So I think it's kind of going back to like the chiropractic thing. Like now there's like doctoring professions, kind of like if you like go to college, you might call your professor like Professor Blank or Dr. Blank because they have like a PhD, which is like the doctoral level degree.
Right.
And like it's like if I got my PhD in something, like I'm a doctor of that, like, and there are doctoring professions, dentistry, chiropractic, physical therapy.
I think this person's upset because they are like 6 figures in debt. And someone else who went to nursing school and then became a nurse practitioner who's probably also in debt, but is
maybe less,
significantly less,
but started working earlier.
Yeah, exactly. Is also getting like the same level of respect. I
feel like the white coat thing I think is a symbol that like you're working, like you're in a clinical setting, like you're treating people. It
has nothing to do with your pay scale.
Right. Yeah. Anywhere from like. Physical therapists can have white coats. I think nurses have a white coat ceremony. PAs have a white coat ceremony. Everyone. Obviously,
dentists. Everyone.
Yeah, I don't know why that. I think that's kind of like. I think a lot of people kind of get bitter at that. I've actually heard that before, like in real life.
Well, I also like remember being in college and like professors that did have the PhD, were adamant about like being called doctor, and then other people were like, don't let so and so hear you call me doctor because and there was a misconception too that you were a professor but that didn't mean you had a PhD, which I think there's some confusion going into college about that because I thought everyone was a doctor. Yeah, in college I think that was just but yeah, I think the people that get the stingiest about it are the ones that
stingiest
that went through the whole process, and they want people to suffer as much as they did.
Right, and they probably have like a super high superiority complex.
Right.
And they're like, you will call me and only me, doctor. Don't you dare say it for someone else.
Correct. Not in my presence. Okay, so this one I found interesting because. On top of, you being in PT, one of your personal interests is, physical fitness. Mm-hmm. You used to be a personal trainer. In fact, you used to be mine. So going barefoot is better than wearing shoes. Your feet aren't made to wear shoes, and shoes can screw up your ankles, knees, and hips. Is this true? Are you about to put Nike, Adidas, and all these shoe companies out of business?
So there are some shapes of shoes that can have impacts on your foot because I'm wearing awful shoes right now for this, but that are crushing my toes. But your feet should kind of have like the ability to web and like splay.
Yeah.
Like the toes, and a lot of shoes, I think, in an effort to have like this sleek design, have like this really narrow toe box that kind of like crushes your toes together.
Yeah. All heels.
Oh yeah, heels for sure. But also like the position they put the feet in. That's heels in general. But even like regular shoes. Actually now you can go and you can buy shoes that have wide toe boxes that are more like appropriate for the shape of the toes. Mm-hmm. But yeah, they used to like all the regular shoes. Like back when we were in high school, all the shoes I think had like that really narrow toe box that kind of bunched the toes together.
Yeah, and then now they have these shoes that are like knitted and they're like made to look like a sock. But
what?
Like, yeah, like like there are some shoes that they're not like yours. Okay, these are like Chelsea boots.
I was like, mine what, girl? What are you gonna say about my shoe?
No, but like for instance, like I have a pair of like I think they're Adidas, and I'll show you them after, but, like, they're this, like, knit.
She literally said, like yours, and went and touched my shoe, everyone. My Chelsea boot.
That's my mistake. But, like, I have these, like, Adidas sneakers, and they're, like, not, like, they're, like, they look like a knit material. They're not even, and they're really tight on the tip. I'll show you after, but.
That's wild. Are they comfortable?
Mostly, but
Mostly
I did have to, like, break into them. And it was that, toe box thing that was just crazy. And I was like, I think I have a wider foot than I thought.
And definitely things from the foot can go up, like, can go to the joints above. Yeah. But that's, like, with a lot of things, like, the joints above, the joints below, like, it can cause, especially, like, with the foot, like, if you have, like, a foot collapse, it can really cause problems, like, at the knee, at the hip. I mean, things can travel, especially, like, in that area. But I won't say that, I'm not going to go as far as saying that barefoot is the best, because first of all, that's gross. Shoes all I mean, in the streets of Miami, yeah. Yeah, in the streets of Miami, we don't do that. But also, like, if you have really poor foot mechanics with your bare feet, like, you're not, like, solving anything. I personally believe. Right. Like, if I have, like, this crazy foot collapse and, like, my big toe is, like, jutting to the right.
Let me ask you. Is flat foot that big a deal?
In terms of what?
Like...
I mean, it's pretty common.
Is it? Like, I remember, like, in 6th grade, like, we were told you couldn't even, like, join the military if you had flat foot. Like...
I don't know about that. I can't speak on that part.
What is that? How does it affect the mechanics of your foot? Like,
well, the thing is, like, if your foot caves in, like, if the middle of your foot is caving in, it puts your shin bone, like, into the tibia, into internal rotation, like, rotating in. Mm-hmm. And it just kind of it can mess up the proper mechanics of, like, the knee and hip, as well as the foot, because you're just kind of, like, it's just, like... Right. Like, it's just flattening itself on the floor. But it's pretty common. I remember, like, when we first...
I only met one person with flat foot.
Really?
Yeah.
But I feel like people don't admit it because they're afraid to get roasted. Because I feel like I remember...
because, like, there's this misconception that it's, like, weird. Or,
I feel like I remember a phase, like, in middle school where, like, people would see that you had flat feet and they would just destroy you. But I feel like it's so common.
Do you know more than one person with flat foot?
Yes. Yes. I know, like, well...
Yeah.
When I got into physical therapy school and I had to see, like, 60 people's feet.
Right. Law of large numbers and all.
But, I mean, I'm flat-footed, everyone. I'm admitting it.
You're flat-footed?
You didn't know that? I mean, it's not severe. I'm literally taking off my shoe right now. Like... Okay, I have to stand up. Like, if I just chill normally, you can see, like, my ankle, how it...
Yeah, I do see that.
It's not crazy. Like, I'm not, like... It's not severe.
We've literally known each other for, like, 15 years. And
it's not severe. Like, it's not like... I've never had pain in anywhere, like, in my lower body.
Right, and it hasn't affected, like, your weightlifting or...
Right, I mean, I've done weightlifting. Nothing has ever happened with my feet. So it's not like I'm like it's not like my personality, but but I feel like a lot of people have it to some degree. I feel like you just gotta, like, look for it, because they won't say it, because they'll be afraid to get dragged.
Do I have a flat foot?
You have to stand up, girl. I feel like yes. She didn't stand up yet. I think I was just picking up the vibe that I was getting.
I know I don't have...
Okay, but I also believe that it's more common... Oh, hang on, face me? Yeah, you do. I believe it's more common, though, like, after pregnancy.
Okay, PSA.
Well, because I believe. Just because, like, the weight gain and, like, just the way that your center of gravity changes.
That is crazy. I'm out here talking about that I don't know anyone with flat feet, and I am one of them.
I'll do a thorough look after. Yeah.
Okay. This is the last one, and this one I think is really funny because the way the person communicates, I feel like, is something you would say. So
that worries me.
One is, how to deal with patients who go on WebMD.
Oh.
So mine would be seeing people, so this is, their pet peeves and stuff. Mine would be seeing people who read something on WebMD about a disease and then start arguing with the doctor like they know better. It makes my blood boil. And then someone responded and said, perhaps you should improve your skills at communicating to patients why their conclusion is incorrect.
Wow, a double attack.
Yeah, exactly. I feel like I identified with this, like, when I texted you that I was having a problem with my foot, and I'm like, oh, it's plantar fasciitis, like, 100%, and you're like, I mean, maybe, but,
right.
And I'm like, no, but I Googled it, and, like, look at this diagram, and I'm like,
the diagram.
This is what hurts me, and you're like, I mean, maybe, but, like, what are you doing to inflict the pain, like...
Yeah. Yeah. I mean... Yeah, the WebMD Googling is rough because it's also like there's so many things could look the same. So that's just like to start, like a lot of things can cause foot pain. Like there's referred pain, there's pain at the spot, like it could be tons of things. It could not even be like a muscular problem. Like who knows, like it could be anything.
Speaking of which, I think it's back. The plantar fasciitis.
Right. So. The plantar fasciitis.
Right.
Got it.
It's in one foot.
Right. But also, like, let's say you do Google it and you conclude on your own that it's this thing with, like, no testing, no evaluation with any kind of background. And then it's like, okay, then what? You're just gonna, like, throw this shit at the fan and just, like, hope something works, which I guess is great, but I just feel like for peace of mind, maybe just, like, go to the doctor.
I'm very non-confrontational. I'm not going to do that.
I will not go to the doctor.
I'm going to rest. The Google diagnosis.
I'm going to rest. I'm going to just take ibuprofen and call it a day. Got it. Right. Well, ideally, maybe you can go to the doctor.
Maybe.
Or a physical therapist.
I also am not of the school that...
Right, okay. Of what?
that, physical exams are absolutely necessary.
Right, before the age of 40.
Yeah, so those annual exams are really like...
A concept.
Like biannual, like,
Right.
More of like a suggestion.
Right, like stop signs.
Right. All right, but that was the last one. So, okay, I think you did great. So, what is one tip, and we're going to close it out. What is one tip that you would share for someone who is in your position, or, just a general piece of advice, be it, for PT students, for LGBTQ medical students, you fall into so many categories. Like, tell us your piece of advice. Who are you speaking to?
I think the main thing is just whatever you want to do with whatever barriers you may be facing, whether it's like a gender barrier, an education barrier, whatever it might be. My advice is to analyze yourself, see what you're bringing to the table. There's probably going to be factors that you can't control, but the ones that you can, just see how you can strengthen them little by little. For me personally, obviously, I can't control that I have a penis. I can control that, but I don't want to. So what I could control is the education that I can bring to the table. I can control like the network that I have and the network that I can have. And I think those are the things that I tried tackling. So my version of that was I took the course in Philadelphia for like the internal vaginal exam. I've taken those courses on male dysfunction. I read a lot of research in the pelvic health field. And then for the network, it was really, of course, there's always something like LinkedIn, but for me, Instagram has been huge because I feel like a lot of people, whether it's through Instagram posts or TikTok that they're posting on Instagram or just their Instagram presence in general, people make their brand pretty accessible. So I just looked for people that were in my shoes. I looked for male pelvic health therapists. I looked for pelvic health therapists that have treated women, that have treated men, whatever I was kind of curious about in the moment, and just kind of, planted a seed with them and built some kind of connection with them, even if it's just them knowing that I'm interested, knowing that I'm here.
And is it really just as easy as sending a message and introducing yourself?
Yeah.
It really is.
For me, it has been, yeah. And I've done it with quite a few people now. And I really just say my name. I say what I am, so they don't think I'm a salesperson, because I've been in that role. And I have gotten ghosted with those messages. So I introduce myself. I say, kind of like what I'm reaching for, and I'm open with the struggles that I'm having, and that I'm looking to them for counsel, for advice. And I feel like when people see that I'm being kind of like open with them about why I'm coming to them, they're quick to at least kind of refer me to someone that they know that can help, or they're quick to maybe answer a few questions, or to have a call with me, or, all the way up to potentially offering to mentor me, So I really think it is that simple, and you'll never know if you don't try.
Absolutely. You miss 100% of the shots you don't take. Exactly.
And I had a woman that a pelvic health clinician who I went to a few of her seminars now. I asked her for advice, as I do with people, and she said, I think you're going to be a trailblazer. I can feel it. And I feel like that is all you need to keep going, and to prove to yourself that you can be a trailblazer. And I feel like everyone could be if they take the steps for it.
I feel like I just received that compliment. Like, it's such a good compliment. Like,
yeah, and I think everyone could be a trailblazer if they just, take the steps and decide that they want to be one.
Right.
Very
good. And so where can we find you on social media, if you're open to sharing that, to see what you're up to? Can we connect with you on LinkedIn?
Yes. My social media, my Instagram is just my name, at Julian Colina. And my LinkedIn is also my name, which is Julian Colina.
And we'll see you there as a PT student at University of Miami, right?
Yes. And also exercise physiologist on LinkedIn.
Oh, great. So that's how we know to identify you. So that is the first episode of the Second Round podcast. You are a fabulous guest. Thanks to everyone for listening. You can find us on Spotify or anywhere you get your podcasts, and follow us at the Second Round podcast on Instagram. We will see you in a week.